So yes, I'm going to touch on a little bit, actually picking up from what James was speaking about with the questions, and also picking up on what Ellie was speaking about, picking up on the how we're presenting this evidence to decision makers and different types of evidence. What I will cover is I just wanted to think about the perspectives that we take when we're making decisions and looking at the evidence. And we can to me, I think there's a bit of a tension between whether it's an individual clinical type question or it's a public health perspective. And I'll touch on how we summarize this evidence and the findings, and again, touch on what Ellie had spoken about the certainty of evidence. And yes, of course, you can't have a presentation without speaking about COVID. So I'm from Canada. I live in Niagara Falls, and you can just see that on the map there. And Niagara Falls is in a region, so there's a couple of other cities around where I live. And the Niagara region, there's about 400,000 people that are included in that region. And I think regions became really super important when we were talking about COVID. In particular, back in March 2020, there were very few cases in our Niagara region. And when it first started out and they were keeping track of when people had COVID, if you can believe it, when it first started in those early days, they were publishing the names of the people who had COVID in the newspapers and online in the Niagara region. And as it built up, I could see myself right there in that little block of cases. Just before I was recorded, they stopped publishing the names. But I only say this to say that at that time, everything was very much on an individual basis. We were thinking about COVID on an individual patient basis. But as time went on, we started having these huge numbers, and we no longer thought about it as an individual per se. The numbers were starting to look like on a population level. And we started recording information about how many cases were there per 10,000 people in the population of the Niagara region. And eventually we started seeing numbers in the millions and how many cases were per million, etc. And it really changed from an individual to a really very much a public health, global health issue and perspective. And then something happened when we started rolling out the vaccines in Canada. And we had some information from policymakers and public health units and public health decision makers. And it switched back to this individual, from the public to an individual. Each person needs to do a self-risk assessment. It became about me and the self and my decision, which to me was a bit of a change again from an individual to the public health to individual. And I think it's sometimes a struggle for me actually when I'm trying to put together information and evidence for public health decision making. Is this a public health decision? Is this more of an individual clinical decision on a patient level? Or is it both? And we need to consider both. And should we make this distinction at all? And this comes up time and time again from work that we're doing. I think it really does make a difference what that perspective is, depending on how you present that evidence. So if you can imagine, we were working on cervical cancer screening. So, we're thinking of, this is a public health intervention. We're thinking about the different tests that could be provided for cervical cancer screening. If you know anything about cervical cancer, there are different tests that can be used. So HPV tests, there's Pap tests or cytology. In a lot of other countries, there's a visual inspection of the cervix with acetic acid. They're looking for lesions for cervical cancer, not necessarily looking for cervical cancer itself. What we've learned even from COVID, tests have different sensitivity and specificity. So some tests will have more false positives, where we've diagnosed people with cervical cancer lesion when in actuality they don't have a lesion. or some false negatives where we've missed people who actually have a lesion. And after finding that lesion, there's going to be treatment, and we'll treat on that lesion. And so that's, what's happening with cervical cancer. So how is this playing out on this individual public health perspective? We'll have, maybe take a minute to think about, how does screening for cervical cancer, what would you be looking at if you were approaching it from an individual level versus if you were looking at it from a population level or a public health intervention? What types of outcomes would you be thinking about for cervical cancer screening? And it can be quite different. When we were thinking about the individual's risk, we were thinking about this woman in front of you who has this risk of having cervical cancer. What are the chances that this woman who's making a decision about being screened might have an unnecessary treatment from a false positive? If she's treated, what is the possibility that she will experience any reproductive outcomes from that treatment? She might have a risk of preterm delivery. And so you can think of it as an individual decision that a woman might need to make. If you're thinking about it more on a public health or population level, you might start to think about and want evidence about what is the population incidence of cervical cancer right now? What is the incidence of these cervical lesions in the population? If we were to do these tests across all women of a certain age, how many tests would that mean that region or country would have to provide? And then if we do all these tests, how many treatments would we have to provide? The number of treatments could be quite high, and they could be treatments that were unnecessarily done. They could be false treats based on false positives, for example. And then the number of treatments really does have an impact on the healthcare system. So you can see very different outcomes that you might look at if you're approaching a question from a different perspective. We, of course, at WHO, we took a population perspective, and we had to look at evidence that answered and found evidence or data for these outcomes. So we conducted some systematic reviews of the evidence for these different tests and what were the effects of those different tests once you applied those tests and they were followed by treatment, and those effects on those outcomes. And what we tend to do is we tend to provide huge summary of findings from the evidence that we find. And this one is set up across the top. These are the outcomes that we decided to look at. So if I do a test, what is the effect on cervical cancer cases? How many deaths could I prevent? How many treatments would I have to provide across a country or region? And also at a population level, what would be the chances or the numbers of preterm deliveries that would come out of providing these treatments after the tests? And we provided this information for each screening test followed by treatment. If you can look across it, the decision makers could look at this and say, this is primary HPV. If I was to do a screening test every 5 years in this group of women, this is how many cervical cancer cases I would reduce, 851. And if you look across, we have the numbers here. These numbers are not presented on an individual risk type level. These numbers are presented over a population level. So 851 fewer cervical cancer cases out of 100,000 women. So even presenting the evidence in such a way that public health decision makers can clearly see what are the effects on a population level, public level. This one, probably another example, less clinical, if you might say. We're working with a group now in Canada who are updating guidelines for alcohol consumption. So the low risk alcohol drinking guidelines. And we've had some conversations with them about how they can present the evidence quite clearly in their guideline and making decisions about the level of alcohol that should be consumed, that they would recommend to the public. it's the same idea of what we're presenting to the public, to the decision makers. Here are the outcomes that this group thought were important on a public health level. Numbers of cancers, automobile accidents, crime, any of those outcomes at a population level that would be important at a public health level. Those are being presented to the public health decision makers. The systematic reviews were conducted. For cancers, for example, they did a systematic review on lower alcohol intake compared to higher alcohol intake on cancers. They found some studies, whether they found, say, for example, they found 5 non-randomized studies. They had this many people in those studies. And they found that the risk was reduced if you had lower intakes of alcohol with a risk ratio of 0.64. We know that many decision makers do not understand what 0.64 means, and it actually doesn't even tell us what it would mean to their population. And so again, what we are doing is we're presenting this information in tables. Here are our outcomes along the side. This is what we found. We found these studies. And just to note here, again, we're presenting what happens to people out of 100,000. And so it's more at a public health level for the decision makers to really understand what's happening. Also, what we're presenting here is we're taking that risk ratio, that 0.64, and we're applying it to this risk if we were to have an alcohol intake that was at a higher level. So cancers would be 435 if you have an intake at a higher level. If we were to actually do some calculations, we would times it by the 0.64 for the risk ratios, and we would come up with that if we have a lower risk alcohol intake, we would have only 278 cancers. So a reduction of about 150 cancers if we were to reduce the level of alcohol intake across a population. One of the most important parts of doing all these fancy calculations is choosing what is that risk right here, that baseline risk. And if you've ever attended a workshop where we're working on these tables, there's always that question, well, how did you decide that that was going to be 435, that baseline risk? Well, in this case, in a public health situation where they're making decisions, these are probably the risks that are happening at a population level in a certain country or a certain region, and you would look for those risks at that level. It wouldn't necessarily be, again, at an individual level. It's at a population level. The other part is you would be presenting this information, and these numbers look quite fancy. They're great to calculate in these tables, but I haven't yet mentioned, and Ellie did touch on this in his presentation about, we can present these numbers, but we also need to communicate to decision makers how sure we are about those numbers. Many times you'll see summaries provided for decision makers, and the numbers look great, and whatever those numbers came out of the evidence, but they haven't communicated to them, what are the problems, the possible concerns with that evidence? And then that's where the certainty of the evidence came in, and we firmly believe that decision makers need that information, and we have research about that decision makers want that information. And typically, we can think of a few, criteria that can be used. And what has happened is, of course, GRADE has come out as a way to assess that certainty of evidence and doing it in a very systematic way. So one way of telling a decision maker, how are those numbers? Where did they come from? How certain are you that these really are the numbers that will happen? Let's assess it by using GRADE. And if you think to the information that you would want to consider, there's nothing really new about what you would want to consider. You would look at the studies to determine if they're poorly conducted, risk of bias. You would look at the studies to see if there's some inconsistency across those studies. Does one study say something totally different from another study? If so, you would have less certainty in what's happening. And as Ellie said, she spent a bit of time talking about the directness of that information? Do the results not really apply to what I want to know about? I want to know about an elderly population, but I might have data for people who are a bit younger. Is that really going to apply? Should I use that evidence? Will it reduce my certainty in that evidence? Do I have enough evidence? Are there enough people in these studies to make some strong conclusions and have high certainty in that evidence? And is it possible that I'm missing some studies that could have an impact on the numbers that I found? And of course, we have other criteria that may be more applicable to non-randomized studies, and criteria that actually might increase our certainty in the evidence. If we find that really large effects, we might have more confidence or more certainty in that evidence. And there are other criteria for that. But this type of system is at least a systematic way to communicate to decision makers about how certain we are about those numbers. Whether we agree, or do we know that this is actually the way that we want to present the evidence? Is it helpful to decision makers? We have research over the last 20 years about how to assess the certainty of evidence and how to present that information to different decision makers, policymakers, decision makers, managers, and the public, and more. We do have evidence about how that this type of information, the certainty, the numbers are helpful in decision making. And I just point to another effort that's happening where they are pulling together evidence to help decision makers make decisions related to COVID. And I'm just pulling an example from a Maureen Dobbins group at McMaster University, who has pulled together some and done summaries along with the rest of the efforts of COVID End in Canada. But in her discussions and the work that she's been doing with public health agencies, they do want specific information. And this is what they've come back to her and said. Yes, we want a little bit of background, but yes, we want the key points that you found in your evidence, but we also want to know how certain you are about that information. We need to know this when we're making decisions. It's very clear to them that they needed that information. They're also, again, these summary of findings tables, tables laying out, these are the outcomes. This is the effect that we're finding. This is how certain we are about those numbers. That type of information, again, is wanted by decision makers when they're making key decisions. And GRADE is available to help give that level of certainty of evidence. And it can be done on interventions, diagnostic, just like we showed with the cervical cancer screening, and prognosis. The other thing that Nellie mentioned was another type of way of assessing the certainty of evidence, in particular when you have evidence from qualitative research that's answering questions about, what do people view about or think about? What are their perceptions about or attitudes towards something? In this example, towards vaccines, towards vaccines, we still would pull together all that qualitative research and indicate to people, this is how certain we are about the views across groups in the population. So there's also this GRADE CIRQUEL that's available. And many of you may ask, well, that's well and good. That seems really great for decision makers, researchers, etc. But we also know that the public needs this information. They want to see some numbers. They want to know what's happening. They want to know the effects, and they also want to know how sure we are when we are presenting those numbers to them. And that has become very clearly relevant. And this work comes out of the Cochrane Plain Language Summaries. So any Cochrane review that has a summary will have something that's written in a more plain language. And there's lots of work that has been being done, focus groups, interviews, randomized controlled trials, testing and evaluating whether the patients and the public can understand these concepts. And what we have found is that they do, they do want this information as well. So it's not just about the decision makers, it's also about the users. And many of you would actually ask, my goodness, does the public understand these numbers? These are only good for researchers, for example. But we do present this. We did find that they understood it. One thing that we did find out, though, is yes, they want to see these numbers. They want to know that they're available. But they also would want some sort of informative statement, a clear statement saying, this is what happens. There's going to be slightly fewer women if we do this, who will have a preterm birth. And that's the type of information, even these statements we find are very useful for decision makers, not only the public, because it's just a text to summarize that information. So again, all of this is something that's being described in the Cochrane Handbook and the Grade Handbook, for example. And then finally, my very last point that I did want to make is many times we hear from public health decision makers that the certainty of the evidence could be, and often is, low or very low. It's one of the criticisms that people have placed on the grade system. But there are some reasons for why this evidence will be low or very low. And Ellie touched on a few of those issues that could come out and our concerns about the evidence. Regardless of what it does end up as, we know that decision makers, whatever the level of evidence, they need whatever's available, the best available to make decisions. But often, as James said, when we're looking at interventions and we want to know how certain we are about an effect of an intervention, many public health interventions are complex. And so it's very hard when you're doing studies to determine what part of that intervention, so if one, wearing masks, what part of that specifically will cause the effect? It's hard to tease out. If I provide that intervention without all the other things that are happening around it, will I still have that same effect when applied alone? As Ellie mentioned, there's always concern about whether the intervention could be applicable to other settings. So if the study is done in high income settings, will the intervention actually have the same effect in other settings, in low income settings? And so we always have this issue of needing to consider the indirectness. And many times, this is one of the reasons that the certainty of the evidence may be low or very low. The other issue is that many times with public health interventions, there are not as many randomized control trials. They may not be feasible or ethical to do. And so we often have to rely on evidence from non-randomized studies, but there is always the risk of bias, confounding, because we haven't been able to have randomized people to groups that are comparable. There may be missing outcome data. So there seems to be often enough a risk of bias in those studies, which will mean that the evidence may be uncertain because we're not sure if that's really truly the effect. Issue is, can we fix these concerns? Likely not. If a trial cannot be conducted because it's not feasible, that's what's going to happen. We will never have a randomized control trial to answer our question. So often we can't fix these concerns, but it still means that we do need to communicate to decision makers that we may not be certain that this will be the effect that will happen because we only found studies in high income countries, and this may be the effect in low income countries, but it may not be. And so we have less certainty. And just to summarize just what we've covered, I think there is this tension between individual and clinical and public health perspectives. I think part of the challenge maybe, or one of the solutions, is making sure to choose the outcomes that decision makers will need to consider when they're making decisions. We still believe that it's vitally important that we're summarizing the effects. We're showing very clearly this is what might happen to this outcome. And we will apply it to what can happen at a public health level, whether it means at 100,000 people or 1 million people. And we really firmly believe, and we know that decision makers want to be able to understand that information clearly, typically in presenting the number of people it will affect, but also how certain we are about those numbers and how to interpret those. And I'll just end there and see if there are any questions or any comments.
Thanks, Nancy, so much. Just one quick question, Sarah, if that's okay, and then we'll open up to the panel.
Yes, that's great. So I'll just ask one question. There's a couple of questions that are there, but I think they're relevant to the whole panel. So just one question, Nancy. Who do you think should assess indirectness, researchers or the guideline developers or decision makers?
Absolutely. So we always, as a systematic reviewer, we take the first stab and we say, this is how we've assessed our certainty of evidence. We've considered these populations, et cetera, and this is our first, cut of what we think the evidence should be, and how certain we are about indirectness. But absolutely, it would go back to that group making the decision and saying, yes, I agree with that. I really think it is indirect also, or I think it's actually direct, and we're going to change what your assessment was at a systematic review level. Absolutely.